to introduce our speaker for our 8th annual Global Health Pediatric Grand Rounds. We have had 7 previous speakers. They've all been luminaries in the field of global health research, people like Bob Black, Mark Klein, Philippa Masoke, Tina Slusher, and Mark Steinhoff, who have done groundbreaking research in global child health. This year we decided to spotlight a person that we feel is going to be doing groundbreaking research in global child health, one of our own faculty members, Sarah Cusick. Sarah did her bachelor's at Birmingham Southern College in Alabama and then did her PhD at the Johns Hopkins School of Public Health in child nutrition and international health. She went on to work with WHO and the CDC on some pivotal studies on the risks of iron supplementation in areas where there is a lot of malaria. And we were fortunate enough to recruit her as a faculty member to our Division of Global Pediatrics when she and her family moved to Minnesota. And since she's come here, she is an assistant professor in our division and department. She is a KL2 scholar, and she's been instrumental in obtaining 2 NIH-funded grants to look at iron deficiency and malaria. Just as importantly, working with myself, Mike Georgieff, Maria Kropina, and others, she's really helped to develop a completely new research focus for our division and our department on the interactions between nutrition, infection, and neurodevelopment. And this is really very exciting work, and I think the potential for its importance in global child health research in the areas we study overseas as well as here in the United States is really quite tremendous. So it's my pleasure to welcome Sarah, who's going to talk to us about iron deficiency and malaria. Thank you, Sarah.
Thank you very much. Well, no pressure. I have to become a luminary, so hopefully this won't disappoint. As Chandy said, my work is in micronutrient deficiencies, or deficiencies of vitamins and minerals and their interaction with infectious disease. And to date, my research has focused on the interaction between iron deficiency and malaria. And hopefully by the end of the hour, I'll have conveyed to you why that is a problematic coexistence. Oh, I have nothing to disclose. So despite having grown up in the iron city of Birmingham, Alabama, my interest in iron really didn't begin until I moved to Baltimore and began graduate studies at Johns Hopkins School of Public Health. And there it was really where I first learned of the global expanse of iron deficiency. So globally, 4.5 billion people have iron deficiency. And about nearly 1 billion of those have iron deficiency anemia, or the most severe or last stage of iron deficiency. And this is about 2/3 of the world's population. And young children in the first 2 to 3 years of life are one of the groups that are most vulnerable to iron deficiency. So why are these children so vulnerable, particularly children in low-income countries? And it's because they're growing rapidly in their first 2 years. And this rapid growth is in the face of a transition to a more adult diet. And this adult diet is typically plant-based or cereal grain-based and very low in absorbable iron, but high in a compound called phytate, which is simply the storage form of phosphorus in cereal grains and plants. But it also happens to be a potent inhibitor of iron absorption. Further, fresh fruits and vegetables, which have vitamin C, which would enhance iron absorption, are only seasonally available. So when mangoes are in season, but storage capabilities to permit their consumption year-round are lacking or non-existent. So an example is cassava, which is really a starchy tuber similar to a potato, but you can't eat the skin. And it's a staple crop for many in Eastern Africa. And in 100 grams of cassava, there's slightly over 1/4 milligram of iron, and it's not very well absorbed iron. But there's 624 milligrams of phytate. So you can see obtaining enough iron to sustain growth is really a losing battle with a cassava-based or a cassava similar to that based diet. As comparison, 100 grams of lean ground beef has about 4 milligrams of much more absorbable iron and no phytate. The consequences of iron deficiency in childhood are serious and potentially long-lasting. So immediately, lethargy and impaired immunity. But if the period of iron deficiency coincides with a period of peak brain development, particularly in the prenatal period or in the first year of life, it can lead to permanent altered brain metabolism and neurotransmission, impaired myelination, and altered gene and protein profiles. And this in turn can lead to, later on, several years later, potentially irreversible cognitive impairment with global deficits in attention, learning, and memory. And if the iron deficiency occurs later in the toddler years, It can impair what's known as socio-emotional behavior, leading to a child who's more hesitant, more wary, and having less positive affect. And recognizing really the devastating effect that iron deficiency can have on child development, the Lancet recently named iron deficiency anemia as one of the four most important factors that prevents the 200 million children in developing countries who fail to meet their developmental potential from meeting their developmental potential. So because of this role in child development, until 2002, the World Health Organization recommended universal iron supplementation for all children under the age of 5 who lived in an area where the prevalence of anemia was 40% or more. But a study done on Pemba Island in 2002 really brought that recommendation into question, the safety of that recommendation into question, at least in malaria endemic areas. And so Pemba Island is part of Tanzania. It's about 30 kilometers off the coast, and it's got about the same population and also the same size, landmass-wise, as the state of Delaware. But unlike Delaware, it has intense year-round transmission of Plasmodium falciparum malaria, the most lethal form of malaria. So the overall aim of the Pemba study was to determine the effects of iron folic acid supplementation, with or without zinc, on severe morbidity and mortality. And it's important to note, when the researchers who were from Johns Hopkins did the study, it wasn't with regard to malaria. They were just trying to see different morbidity and mortality outcomes in a very large study. And so they actually censused the entire island and enrolled all children, consenting children, between the ages of 1 and 35 months. And this was 30,000, actually more than 30,000 children. It was about 33,000 children. And they randomized the children to daily supplementation with either iron folic acid with zinc, zinc alone, or placebo. And the study began in February of 2002, but about 18 months later, in August of 2003, the iron-containing arms of the study were stopped by the Data Safety and Monitoring Board. And all the children were re-randomized to either zinc or placebo. Because what the members of the DSMB saw was that although children who received iron folic acid supplementation were not significantly more likely to die, they had an 11% increased risk of hospital admission compared to children who received placebo, and a 12% significantly increased risk of having a serious adverse event, which was a composite measure of mortality and hospital admission. And when they looked further at the cause of these serious adverse events, they saw that by far the largest cause was clinical malaria, followed by other infection-related causes. And what really implicated malaria as the primary cause was that researchers were doing simultaneously a study of the same size in Nepal, where no malaria is non-existent, and they found no effect of iron, either beneficial or harmful, with regard to their outcomes. So, as you might imagine, this raised a lot of questions for researchers and policymakers in global nutrition. And the questions primarily related to iron deficiency prevention and iron deficiency treatment. So in terms of prevention, is the universal iron supplementation of children younger than 5 years safe in malaria endemic areas? And in terms of treatment, what is the safest and most effective way to treat iron deficiency in malaria where the conditions coexist? And to give you an idea of how often the conditions coexist, here is the map that I showed you just a little while ago of all of the areas at high risk for iron deficiency. And here's a map of all the areas, everything that's not green, that's at risk for malaria transmission. So you can see if you overlaid the maps, they would cover many of the same regions: South and Central America, Africa, Southeast Asia. So after Pemba, the WHO came out with new guidelines. In terms of iron deficiency prevention, universal iron supplementation is no longer recommended in malaria endemic areas, and that screening for iron deficiency should be done before giving iron. And it sounds simple enough, but it's actually really quite expensive. So even a HemaQ cuvette would cost about $1. And so this would add thousands of dollars to iron supplementation programs, which made many of them unfeasible. And in terms of iron deficiency treatment, infants and children who have iron deficiency in malaria endemic areas should be treated with both antimalarial and iron therapy. The only problem with this recommendation is that studies that have done this, given both antimalarial treatment and iron to a child who has both iron deficiency and malaria, have had really pretty unsatisfactory results. There are modest gains in hemoglobin, but the anemia is not resolved. The iron deficiency persists, and there are often more frequent episodes of malaria. So to understand how malaria might be affecting iron metabolism, it's important to have an idea of where iron is going in the body. So iron absorbed in the gut is bound to transferrin and taken primarily to the bone marrow for hemoglobin synthesis and erythropoiesis. Circulates as a red blood cell for about 90 days, and then it's engulfed by macrophages of the reticular endothelial system in the spleen, liver, and bone marrow. Red blood cell broken down, hemoglobin broken down, but iron is salvaged. And so depending on the status of the individual, if it's iron replete individual, then iron will go into stores. If not, it will be bound to transferrin and taken back to the bone marrow. A couple of important things to point out is that iron absorption is regulated by the iron status of the individual, with somebody who's more iron replete absorbing less, and somebody who's iron deficient absorbing more. And also what's interesting with iron is that once iron is in, it's typically in. The only way to lose body iron would really be through blood loss, because about 75% of iron is circulating as hemoglobin. So malaria really wreaks havoc on this nice system of iron metabolism and storage. So in response to a malaria infection, a young child will mount a very strong pro-inflammatory response with high levels of TNF-alpha and IL-6. IL-6, in turn, induces production of hepatic protein hepcidin, which has been found to degrade another protein called ferroportin. And ferroportin controls iron efflux, or iron exiting, from cells of the reticular endothelial system, storage cells, and also enterocytes. So iron, in the face of malaria, literally becomes trapped in its storage compartments. Can't be used for red blood cells, or importantly, for the developing brain. And iron that's absorbed becomes trapped in an enterocyte, and it gets sloughed off in the intestine, cannot come in. So as you can imagine, giving an oral iron supplement at this situation, the iron would not be optimally absorbed or optimally used, and further may actually benefit the parasite. So by this time, I had gone to CDC in Atlanta, and it was interesting. There's another perspective. So with the Pemba fallout, we were having to deal with countries who were questioning, should we still be giving iron? Should we stop our iron fortification program? So this was a really big question in the global nutrition world. So I moved to Minnesota with my family at the end of 2008 and had the good fortune of meeting two really incredible mentors, Dr. Michael Georgiev and Dr. Chandy John, who sometimes go by the alternate names of iron and malaria. And together, we put together an application that really tries to get at an alternate way for treating iron deficiency and malaria where they coexist, a different way than giving both iron therapy and antimalarial treatment at the same time. And this study takes place in Kampala, Uganda, and Dr. John is PI, and it's entitled Acute versus Delayed Iron Therapy, Effect on Anemia, Iron Status, and Cognition. And the study takes place at Mulago Hospital, which is part of Makerere University, and it's the largest referral hospital in Uganda. And our team is a really incredible team that Dr. John has worked with for over 10 years. The data staff and physicians, nurses. And the overall premise of the study is, rather than give iron and antimalarial treatment together, what if we cleared the malaria and associated inflammation first, and then gave iron when it was better able to be absorbed and used? And the literature had suggested that the malaria-related increase in hepcidin levels would be resolved by about 4 weeks after the episode. So what if we delayed iron? What if we treated the children for for malaria, and then gave iron 4 weeks later? So would this lead to improved iron status and better resolution of anemia, fewer malaria episodes by giving iron after the parasitemia has cleared, and ultimately better cognitive and behavioral outcomes? And this corresponds to AIM 1, 2, and 3 of our current study. And this study is nested in an R01 of Dr. John on the pathogenesis of neurocognitive impairment in severe malaria. And our study enrolls children with cerebral malaria, severe malarial anemia, and community-controlled children. And aims to enroll 100 children in each group, and the children are between 18 months and 5 years. And all children are screened for iron deficiency by the indicator zinc protoporphyrin. And children who have a zinc protoporphyrin level of 80 micromoles per mole heme or higher are randomized to start a 3-month course of iron as ferrous sulfate syrup, concurrently with antimalarial treatment at baseline or 4 weeks later on day 28. So children who get it at baseline are children randomized to the immediate group, 4 weeks later to the delayed group. And then our assessments are to compare iron deficiency status, markers of iron status, and anemia at 6 and 12 months in the immediate versus delayed group, and this would be AIM-1. Also to compare the frequency of malaria episodes and hospitalizations at 6 and 12 months in between the 2 treatment groups, AIM-2, and different cognitive and behavioral outcomes between the 2 groups at the same time periods, which is AIM-3. To date, we have 169 children enrolled, and 123 have completed the 6-month follow-up. 88 have completed the 12-month follow-up. Laboratory analysis on most of the iron markers is still ongoing, but we do have some baseline characteristics shown here. So the children, and these are children, the children in the severe malaria group are simply children who present to the pediatric acute care unit at Mulago. So they're all about roughly 36 months or 3 years old. The distribution of sex is relatively the same in kids in cerebral malaria. We found many more males than females in severe malarial anemia, which is consistent with others' reports in the literature, and slightly more females than males in the control group. Hemoglobin is quite low in kids with severe malaria, as you might expect, about 7.2 grams per deciliter in cerebral malaria. And per the definition for severe malarial anemia of kids younger than, lower than 5 grams per deciliter of hemoglobin, their average hemoglobin is 4.5 grams per deciliter, and higher in community-controlled children, as you would imagine. Zinc protoporphyrin, again, higher, iron deficient, but also reflecting some inflammation. You can see that it's very elevated, so that's the median level and then the range. So everybody in the cerebral malarial group and the severe malarial anemia group was higher than 80 and was randomized to get immediate or delayed iron. And in the community control group, the median was 78. So it was actually just over half of these kids did not get iron, and then the other half were randomized to get either iron immediately or delayed, or 4 weeks later. We've also been able to begin baseline neurobehavioral assessment with the help and expertise of our co-investigator, Maria Krupina. And she and colleagues at the Center for Neurobehavioral Development have developed a time sampling coding scheme of 9 different neurodevelopmental variables. And they're shown here, and they're roughly in 3 broad categories. And we're able to, or she's able to, assess these in videotaped interactions with kids in our study, and specifically inattention hyperactivity, fearfulness, and positive affect. And the ones that I've put an asterisk by are those that, even at baseline, with somewhat limited numbers of tapes, are already being able to find some significant differences. So here I have overall social initiation. And for comparison, we divided the kids into cerebral malaria, severe malarial anemia, iron deficient community control kids, so ZPP above 80, and non-iron deficient community control kids. And then we used this latter group as our reference group to compare each of the other groups too, and that's what the p-value is representing. And the higher score represents more optimum behavior. So you can see that all 3 groups had significantly poorer overall social initiation scores than non-iron deficient community control groups at baseline. It was marginally significant for the iron deficient community controls. And additionally, children severe in the SMA group had a significantly poorer overall positive affect. and a poor overall social responsiveness score. And all of these scores, I should say, are adjusted for age. And so while the real interest of the study will be to apply these tests at 6 and 12 months and compare the outcomes between the immediate and the delayed groups, these results were exciting for us because we're able to see that this coding scheme is already detecting significant differences at baseline among the groups and should be a good tool to use for outcomes later on. So far at 6 months, we've seen, in terms of the AIM-1 of iron status and anemia, we still have to look at other iron markers in the plasma, but there's no difference in ZPP level between the I and D group, and also no difference in hemoglobin between the I and D groups. In terms of the second aim of malaria morbidity and hospitalizations, no difference yet between outpatient visits, but there is a trend towards more hospitalizations in the immediate group versus the delayed group. And we're still compiling data on cognitive and behavioral, our cognitive and behavioral aim. So I've also recently begun a study in RO3 that aims to directly track the path of an oral dose of iron given during a malaria infection. And really the only way to do this is through the use of iron-stable isotopes. And what the use of iron-stable isotopes permit is to directly compare the percentage of an oral iron dose that is incorporated into red blood cells. And I can compare this in children receiving iron immediately versus delayed. So what percentage of the oral iron dose winds up in red blood cells? So it's an indirect measure of absorption. And with this project, we're collaborating with Dr. Stephen Abrams at the Baylor College of Medicine, who's the isotope expert in the group. And there are 4 iron-stable isotopes, and they all occur in nature, and they're all non-radioactive. And the 2 that are used most frequently in research are the 2 least prevalent, so iron-57 and iron-58. And again, the premise behind iron-stable isotopes is that they localize into red blood cells, and that permits direct estimation of how much iron from an oral dose is incorporated into the red blood cells. And then once the isotopes are given, and it's really just a form of very expensive ferrous sulfate, is iron-57 ferrous sulfate rather than iron-56 ferrous sulfate. So after the isotope is given, a sample of blood is taken 14 to 20 days later, and the enrichment of the administered isotope is calculated. So basically a fraction of how much 57 there is relative to how much 56 there is. And this is done by very complex and complicated formulas and done by Dr. Abrams. So in the RO3, we're actually using both iron-57 and iron-58 because we're interested in looking at iron absorption and incorporation at 2 different time points. So we're enrolling 100 children between the ages of 6 and 36 months. This is the time at peak risk for iron deficiency. They're moderately to severely anemic, so hemoglobin between 5 and 7.9. We didn't want to go lower than this because children lower than this. Is that me? I guess my time's up. Let's see. Okay, might go off again. Children with a hemoglobin lower than 5 are routinely transfused, and that would alter our isotopic calculations. So hemoglobin between 5 and 7.9, positive malaria blood smear, and a fever. So these children at day 0 are randomized to immediate or delayed iron. And I should point out that this study is not nested in the UA one, but it's a separate freestanding study with different inclusion criteria. All children are treated for malaria. And then after a blood draw, all children receive a dose of iron-57. Children in the immediate group then get 4 weeks of daily iron supplementation at home, just with Ferrinsol. On day 28, all children return to the hospital, and after a blood draw, receive iron-58. And then children in the delayed group get their iron at home for 4 weeks, and all children return to the hospital for a final blood draw on day 56. And what this design permits us to do is to compare red blood cell iron incorporation on day 0 in the immediate group versus day 28 in the delayed group. So what is the percentage of iron that gets into red blood cells at the time that the iron supplement is initially given? which is the primary aim of the study. And then the second aim is to determine overall hematological recovery in the immediate versus delayed group between day 0 and day 56. So what are the changes in hemoglobin and other markers of iron status, such as ferritin or transferrin receptor? So the contribution of this study will be to provide direct evidence of the path of oral iron that's given during a malaria infection. And it will also, with the UO1, together establish a physiologically based timing framework upon which future interventions aimed at increasing iron availability while reducing inflammation can be tested. And one intervention that I'd like to test in that framework is vitamin A. So there's a lot of evidence that vitamin A might be beneficial in both malaria and in terms of having an anti-inflammatory effect. So vitamin A downregulates certain specific pro-inflammatory cytokines, TNF-alpha and IL-6 in particular. 9-cis-retinoic acid, a form of vitamin A, enhances clearance of parasitized red blood cells and reduces secretion of plasmodium-induced TNF-alpha. Vitamin A supplementation significantly reduced malaria febrile episodes by 30% in kids in Papua New Guinea. And a more recent study shows, interestingly, that in rats, at least, vitamin A deficiency increases hepcidin expression. So a deficiency of vitamin A associated with iron trapped in storage compartments. And I also have data from severely anemic children in Pemba that vitamin A very rapidly clears or reduces inflammation and mobilizes iron. So my doctoral research was actually a sub-study of the sub-study of the now infamous Pemba study. And there's nothing too infamous about my results. But I had all of the severely anemic children in 2 different regions of the study, rather than just randomizing them to possibly receiving a placebo with the overall study, were entered into my sub-study. So I had a community-based sample of 139 severely anemic, here defined as less than 7, children between the ages of 4 and 48 months. And each child received a single dose of vitamin A, or antimalarial, which was sulfadoxine pyrimethamine, or SP, and a 3-month course of iron and B vitamins. But for the first 72 hours, children were randomized to receive only vitamin A or SP. And then on day 3, they would come back and they would receive the alternate treatment, and then everybody would begin their course of iron. And so what this permitted us to do was to isolate the short-term effects of vitamin A and SP on several different iron status and erythropoietic indicators. So here are the 72-hour effects of the antimalarial treatment. Hemoglobin didn't change significantly in 3 days, which you really wouldn't expect given the time course of hemoglobin. Malaria parasite density declined significantly. C-reactive protein also declined significantly. But ferritin, which is way higher than it should be for children in this age, did not change significantly. And reticulocyte production index also did not change significantly. So in the same time period, children who got vitamin A, hemoglobin didn't change significantly. Malaria parasite density didn't change significantly. But CRP concentration did decline significantly. Ferritin declined significantly. And reticulocyte production index increased significantly. So what this suggests, or how we interpret it, is that vitamin A in just 72 hours significantly reduced inflammation, mobilized iron from stores, and stimulated the production of new red blood cells in just 3 days. So different research questions. For a larger study that I'm just starting to write, an RO1 application, would addition of vitamin A to a delayed iron regimen further improve iron availability and reduce malaria episodes, leading ultimately to improved neurobehavioral development? And a second question would be if iron therapy and antimalarial treatment have to be given at the same time, which for many reasons or many situations, settings, they do have to, just for logistical reasons. It's very difficult in many areas for mothers to take their kids to health clinics and at all, much less to do it again 28 days later. But if you gave vitamin A along with the iron therapy and the antimalarial treatment, would it provide a maintained anti-inflammatory effect, permitting sustained improved iron absorption, distribution, and use, even if you had to give the treatments at the same time. So this is my working study design. So delayed iron with vitamin A, delayed iron with no vitamin A, which would be the comparison or reference group, and immediate iron with vitamin A. And then assessing, with a longer-term study, permit assessment of long-term iron status, malaria morbidity, an important safety question, and finally neurobehavioral development. So hopefully in the next year I'll have good news in terms of the successful implementation of the study. So that's really it. I'd like to acknowledge my fearless KL2 mentoring team of Dr. Chandy John, Michael Georgieff, and Jim Hodges, and my Ugandan colleagues, Dr. Robert Apoka and Ezekiel Muper, and finally, the best study coordinator in the world, Andrew Simata. So thank you very much. Yes.
So one time I was introduced at a conference about saying, here's Mike Georgieff who's going to talk about iron, the bad boy of nutrition. And I'm now conferring the bad boy label to Peter. So you really strikes me that you're really playing with fire here. And in particular, something I think you talked about earlier is that obviously iron is necessary for every rapidly dividing cell. And that's why iron is important for brain development. Siderophilic bacteria and cancer cells and siderophilic malaria will be happy to take any iron that's available and multiply really, really fast. Any highly metabolic cell needs a lot of iron. So in your vitamin A study, where you are reducing inflammation, and IL-6 and CRP, by the way, are important in that regulation of hepcidin. That's basically how that molecule works. Aren't you running the risk that you are not just, that your erythropoietic response is actually a biomarker for what your malaria might be doing with the iron as well? That is, if you're able to liberate iron, great, it's going to go to the red cells, it's going to go to the brain, and it's going to go to the malaria as well. Now, the one way you're going to keep that from happening, from having increased malarial episodes, is really to keep them on some sort of an anti-malarial. But if they stop their anti-malarial, it seems like you've really put these kids at big risk.
Yes, I definitely see your point. I think one thing, too, and one reason to use vitamin A is I cited one study that's found that it has beneficial effects in terms of malaria itself, so reducing.
How's that helpful?
I'm not honestly sure of the mechanism, but it reduced febrile episodes, and it also has been found to be beneficial in malaria and other studies as well. And I know that if that's simply through an anti-inflammatory mechanism, that's just the same thing as we're talking about.
Right.
But it seems vitamin A is kind of picky with its pathogens that it seems to be beneficial towards. So it seems to be really beneficial towards measles and tetanus, but it seems to not have an effect towards HIV, for instance. So it does seem to have a specific beneficial effect in terms of malaria, and I think that would be an important question that reviewers will have, and that I'm going to need to look into more in terms of putting kids even at further risk. So basically giving more iron to malaria.
They have to build some sort of safety into it that with people monitoring in some way that if they come off their antimalarials, would you take them off their iron then, or?
If they
Yeah, if they're not compliant.
yeah,
Big issue
and
to run into in that study.
increasingly, I mean, Dr. Rebecca Stoltzfus, who was one of the PIs on the Pemba study, she recently just came out with a commentary saying that iron deficiency programs and malaria programs, they do need to work in concert. They have to work in concert. And that doesn't necessarily mean giving them at the same time, because we all know that, well, we can see that doesn't work. But yeah, I mean, I think a safety valve would have to be put in place, because it really is, it's a dangerous situation. So you give kids more iron, and they're more likely to get the malaria, and that can persist even during treatment. So I would have to think more about, I think we'd have to put some sort of safety net in there, as you said.
At a global health level, is that practical to extent? And I don't know the tolerances of the two drugs, whether
Yeah, no, and I
you'd
think,
like to stop one or the other. It's just
and I think there's a question too about in terms of, antimalarial drug resistance, and you don't want to give the antimalarial too frequently because that's the other question that you have to balance it with. So, but no, that's definitely an important consideration. And another, I'll have to take on the bad guy, bad girl role. Yeah. Yes.
Reason to believe that indigenous diets in these areas of widespread deficiencies used to have more of the things we find them deficient in, or is it that the people actually evolved to always be deficient in something?
That's
Are we wrong about what's deficient?
It's a really good question. Somebody asked me that question when I've been talking before, and I don't know that the diet has evolved. I do know that I've read papers on how climate change has reduced, has made more diverse crops have not been able to grow as well, and so I know that is changing what the world is eating. But in terms of evolving to become iron deficient, I guess it's possible because it does it does seem to be somewhat protective against malaria and other pathogens. So there certainly is an interesting sort of evolutionary question here as well. And the whole acute phase response is to keep the iron from invading pathogens. So.
It seems evolutionarily unlikely that people would have evolved to have such a mismatch between their diet and developmental.
Right.
If that's really what we need, unless it's some other benefit.
No.
that same question raised about, the breastfed babies have a threefold higher rate of iron deficiency, and it's a form of eczema. Is there some reason why human milk has relatively low iron? By the way, it's not there's a rumor there's no bioavailable, it's probably not. The fact is, it's supposed to be apparent for whatever reason. It's low. The thinking currently is along with what you're saying, which is you're then presenting less of a metabolic substrate to siderophilic bacteria. Michael Zimmerman, who's another international nutrition researcher, has shown a shift in the microbiome of children who are fed iron, supplemented with iron, a little more pathogenic after more E. coli and so on. So there is that effect, and ultimately you have to ask where's the equipoise in terms of a few IQ points right here versus mortality by horrible infectious disease on the other hand. That's a good question.
Yes.
Along those lines, these children typically don't just have iron deficiency for a region. It's micronutrient deficiency.
Right.
So for 19 other micronutrients, probably consider zinc is a big one.
Sure.
They looked at a lot for instance.
The larger Pemba study, so once they did, when they re-randomized everybody to zinc or placebo, at least in that setting, they did not find a beneficial effect of zinc in terms of malaria. But I know that others have found different results, so there's definitely, I think it's uncertain in terms of zinc and malaria, but certainly zinc is a critical micronutrient. And I think one that often gets sort of overshadowed by iron. Hard to measure, too. And it's harder to measure in the field than iron is, yeah. We are assessing Helminth infection at baseline, but we're not capturing incident Helminth infection. So if somebody were to get it, we're only measuring it by a stool Helminth count at baseline. And in future studies, I understand that a PCR assessment of Helminth count, particularly hookworm count in stool, is a much more accurate way to assess that. So they're treated for Helminth. Yeah, they're treated if they have Helminth infection.
The neurodevelopmental studies that Maria is doing, I think are really interesting from a couple of perspectives. The trade-off in terms of iron deficiency, which has, great effects, but they're not huge. They're there, but they're not horrible. Chandy has spent a fair amount of time studying the effects of cerebral malaria on neurodevelopment. And
Right, right.
development is, we've got this knockout mouse that really do need iron. But that's not to say that anemia and the hypoxia at the tissue level that goes with that also isn't bad.
Right.
So you're already starting to see some differences even at baseline in your group that might start to address what can be ascribed to anemia, what can be ascribed to having calcium in your brain.
Right.
What can you ascribe to iron deficiency itself?
Right, right.
Those tests that you have pulled out there, you might tell the audience where they come from. Those are actually targeted in areas that are known.
Right, that are known to be deficient in children specifically with iron deficiency. And it was modified by a coding system developed by Dr. Betsy Lozoff in Michigan. And it specifically, as he said, targets areas known to be deficient in children with iron deficiency. So getting at the socio-emotional deficit, so increased hesitance, wariness, decreased positive affect. And so looking for 9 specific behaviors, and it's a very tedious process, I've learned, in terms of picking 5 minutes at the beginning and then dividing it into 30-second segments and coding in each of those 30-second segments, and then 15 minutes later doing it again, and then at the end another 5-minute segment. So it's actually quite a tedious and intense procedure to look for those specific behaviors. And that should be able to help us discriminate at baseline which of these roles are, or which of these behaviors are, like he was saying, specific to iron deficiency and which tend to be not specific. So it does seem like iron deficiency is playing into some of the deficiencies, at least seen at baseline. And we can see if it's more or less, or if it's changed by either immediate versus delayed treatment. Yes. Vitamin E levels? I don't know about vitamin E levels in these kids, but I think it would be important because of its strong antioxidant properties. And it vitamin E? Well, I know that vitamin E is a strong antioxidant, and we're actually proposing to look at it in an upcoming study. Vitamin E deficiency from diet, in my understanding, is actually simply from a dietary deficiency is pretty rare. So we hadn't actually looked at those levels in these children. No, but I'm planning on looking at it in baseline samples of the RO3, looking at vitamin D levels, because that hasn't, to my knowledge, been done in Uganda to get an idea of vitamin D deficiency. And it I was actually talking to Dr. Linda Polgren about this too. Vitamin D could have actually similar effects as vitamin A in terms of anti-inflammatory and immune modulating effects. So we're interested in pursuing that as well. Yes?
I just observed that it's always good when you're doing studies, even when you replace the therapies that seem benign, to one, have a placebo arm, and 2, have a DSMB. So what is your DSMB going to be looking at in terms of adverse consequences?
So the DSMB for my study, or for the U01 that's ongoing, we do have a data safety and monitoring board already put together, and so the head of that board monitors all of our serious adverse events or hospitalizations or deaths in real time. So the head of the board, she's a statistician who has extensive history with clinical trials, monitors the hospitalizations in real time. So then we're proposing a second meeting happening when half the children have finished the entire study, and then they'll look at the SAEs, the severe serious adverse events, and the immediate and delayed arms, and see and we have stopping rules in place for the study as well to make sure that if there's a large difference in the immediate group or the delayed group, the study will be stopped. Yes.
I don't know about that specifically, but the availability of mosquito netting for sleeping and things like that. Are these things readily available to the population?
Well, they're given out to kids in our study. So all of the children in our study do receive a mosquito net. And, they're easy to buy and find in Kampala. how much, I mean, they're relatively expensive in terms of what the villagers can afford. But all the children in our study do receive a mosquito net. Okay, thank you very much. Thanks, I felt like it went by so fast. Was it going too fast? I got out of breath.
Take care.
Oh, thanks.
Are you guys using brief or CBCL, or what are your measures?